Hello everyone, I'm Dr. Rajsheker Kollipara, anesthesiologist from United States. Today we are going to talk about basic ECG interpretation. ECG or EKG, both are interchangeable, is an important diagnostic tool in medicine. However, you always have to clinically correlate with the patient. Whenever you're interpreting ECG, you have to correlate clinically with patient's clinical symptoms and signs. With practice, you can master EKG interpretation. First of all, I'm sure everybody is familiar with the ECG paper, ECG grid we call this, certain waves and complexes. Just let's start with the grid. ECG paper has big squares. This is a big square, and each big square has 1, 2, 3, 4, 5 small squares. And ECG paper speed is always set at 25 millimeters per second. Okay. The horizontal axis measures the time. Each small square represents 0.04 seconds, which equates to 5 small squares equal to 0.2 seconds. That is the time. This time comes in handy when you're trying to measure the intervals of P waves, QRS complexes, etc. and etc. So you should know this. 0.04 seconds represents one small square. So one big square represents 0.2 seconds. Similarly, one small square is 1 millimeter or 0.1 millivolts in amplitude. So 5 small squares is 5 millivolts. One big square is 5 millivolts. So 2 big squares make 10 millivolts. Now that's about the grid, the times and the amplitudes. Now you have to know this is a normal ECG complex which has a P wave, a PR interval, a QRS segment or QRS complex, ST segment, a T wave, and in some cases a small wave called as U wave. PR interval measures from start of the P to the beginning of the Q wave. Similarly, the QRS interval starts from end of the beginning of the Q wave and end of the S wave. That is a QRS interval. Okay. ST segment is normally horizontal. In certain conditions it may be raised or elevated or depressed. Okay. This is ST interval, and Q to T interval, that is the distance from the Q to end of T. Beginning of Q to end of T, that's called QT intervals. That is important in certain disorders like hypocalcemia and hypercalcemia. So you have to know these complexes, the intervals, etc. Along with this grid, the times and the amplitudes of the small squares. When we have an ECG in front of you, we are tempted to interpret immediately by looking at the abnormalities and all that, but I suggest you to make it a habit to go approach the ECG interpretation in a systematic way, and it won't take too much time once you get used to that habit. For example, once an ECG is handed over to you, make sure that the ECG is technically correct, because sometimes if an ECG technician, it's a human error, natural, nobody does this on purpose, but if the leads are misplaced or not placed correctly, you may have a wrong interpretation based on what was recorded because of the wrong placement of the leads. So you have to make sure your EKG is technically correct. How do you know that? First of all, make it a habit to see the speed of the EKG paper. It's always listed in all the ECG papers. It has to be 25 millimeters per second, the speed of the paper. Then the next thing you should be quickly noticing is the amplitude. This is the amplitude marker. Amplitude has to be definitely 10 millimeters. This, this 5 each is 1 millivolt, 0.1. So small squares of 5.5. So 1 millivolt, that's amplitude. So this amplitude should be correct. 2 big squares. To make it simple, paper speed should be 25. Amplitude should be, this marker should be 2 big squares. This is always there. You go and see your EKG paper, this will be there, okay? Now, another thing is paper speed. We talked about standardized mark, that is 10 small squares, and negative complexes in AVR. So AVR, first thing you get the EKG paper, you quickly see this one, 20 speed, the amplitude, and look at your eyes should focus on AVR, and AVR should always have negative complexes. See this, these are negative, downward. P wave is down, QRS is down, T is down. If that is positive, that means you can safely say that the EKG lead placement was not properly done, that EKG was not technically correct, so it has to be repeated. But make sure, so you have to make it a habit to look at these 3 points to make sure that your EKG is technically correct. That is the first step in interpreting the ECGs. Now, after looking for those 3 steps to make sure that your EKG is technically correct, next thing is you have to scan all the leads for some general rules. There are certain general rules you have to scan. Okay, one is R in lead 2 should be taller than lead 1. So this is lead 2, R wave is taller than lead 1. That is a general rule. So you have to make it a habit to look into that one. The next one is AVF has taller R than AVL. Just like lead 2 has taller R than lead 1, AVF has taller R than AVL. That is another rule. Now we already discussed AVR, all leads should be negative. That is a rule. 3. Okay. Now next thing is R wave should progress slowly. That means it progressively gets taller from V1 to V5. For example, V1 R is just small. Then V2, just now the small R wave. V3, it's progressively getting longer. And V4, it is again getting longer till it gets a little bit taller in V5. And it becomes V6, it becomes smaller than V5. That is how R wave should be progressively getting taller from lead V1 to V2, V3, V4, V5. And then it gets a little shorter in V6. By the time R wave appears in V3, it should be at least minimum 3 millimeters and above. If it is not there, or if the R waves are not progressing the way they should be, that means the cardiologist, or you can interpret if the rest of the ECG is normal, if nothing is showing up, if only R wave is not progressing, the cardiologist, or you can label it, they always read the ECG as normal sinus rhythm or normal EKG with poor R wave progression. What does that imply? And a lot of times you face this kind of reading when an EKG is read by your colleague. Okay, or you yourself will be reading that way if nothing else is visible on the EKG. Poor R wave progression is very important because it is defined, first of all, defined as R wave is, by the time R wave reaches V3, it should be getting taller. If it is less than 3 millimeters, that means R wave is not progressing correctly. That is called as poor R wave progression. That could mean it's an anterior MI, it could be a left ventricular hypertrophy, it could be a right ventricular hypertrophy, or it could be a normal finding. So it could be a normal. That is the reason when I first started, I said you always should correlate clinically. Just because you have a poor R wave progression, you cannot say that patient has MI or anything, a left ventricular hypertrophy. You have to correlate clinically. That is the reason why you have to correlate clinically all the time when you're reading ECGs, okay, or interpreting ECGs. So poor R wave progression, now you know that. For example, if a patient comes to you, or you have to refer your patient for surgery or some other reason to some other specialist or some other testing to be done, if you interpreted his or her EKG as being normal, nothing else is going on, and clinically is fine, and there's only one thing that is showing up is poor R wave progression, you can rule out from the clinical history there's nothing going on, then you can safely call it as a normal finding and then proceed appropriately. Like if he has to go for a non-cardiac surgery, you can safely clear the patient. You don't have to be worried about that poor R wave progression, because it could be a normal finding and you already correlated clinically. Now, when you're interpreting ECG, as I said, for everything it has to be like a systematic approach. Otherwise, if you start interpreting haphazardly, if you develop that bad habit, you could miss certain important findings. Systematic approach, I put this as a RAISE, R-A-I-S-E. If you remember that, R for rate and rhythm, A for axis determination, I for interval measurements, S for ST segment changes, E for enlargements and electrolytes disturbances, or for hypertrophies, enlargements or hypertrophies, etc. Now, if you follow this, then there is very less likely chance that you will miss out on any important findings, okay, or events. Now, rate and rhythm, R. Remember that R is for rate and rhythm. Of course, it's easy to calculate the rate, heart rate. All you have to do is count the big blocks. We talked about those 5 big blocks with 5 squares in each block. That's a big block. Take any 2 QRS complexes and count the number of big blocks in between those 2 QRS and divide 300 by the number of big boxes between 2 QRS complexes. For example, if between these 2 QRS complexes, let us say there are 4 big boxes, 1, 2, 3, 4, assume that 4. So 300 divided by 4 becomes 75. The heart rate is 75. That is how you get it. If you want to be more accurate, or sometimes there's an irregular rhythm is going on, what you have to do is you count QRS complex for 6 seconds. Again, you have learned that each big box is 0.5 seconds. So, I'm sorry, each big box is 0.2 seconds. So 30 blocks would becomes 30 times 0.2 is 60 seconds. That makes you for 1 minute. So you count QRS complexes and between those 30 boxes and then multiply by 10, it will give you the rate per minute. Now you may be wondering, are we going to count 30 boxes? No. If you go and look at your ECG paper, there is a small mark made below the ECG paper. There is a small line indicate every 30 beats there is a small lines are recorded. Okay. Now, always remember RAISE. Of course, you have to start off with making sure your ECG is technically taken correctly by following the rules, general rules, and observing at the paper speed, etc., etc. And remember the word RAISE so that you can start interpreting in a sequence. R for rate, we discussed about how to calculate rate, heart rate, that is. Now, R for rhythm also. First thing is, look for normal sinus rhythm. That is our idea. And how do you know it's a normal sinus rhythm? If P waves are present all the time, if they all look the same, if the P waves are regular, if each P wave is associated with a QRS complex, then you can safely call that rhythm as a normal sinus rhythm. For example, here P waves are present and they're coming at, they all look the same, okay? And they're coming at regular intervals, P waves, and each P wave is associated with a QRS. It's not like any P wave is missing a QRS, it's associated with QRS. So you have all these 4 criteria, so then you can call that as a normal sinus rhythm. Now, you have to start recognizing or learn to recognize abnormal rhythms, okay? And abnormal rhythms can be either supraventricular or ventricular rhythms. Now, supraventricular rhythms. How do you differentiate the supraventricular and ventricular rhythms? We'll talk about in detail. Supraventricular arrhythmias or rhythms are always associated with a narrow QRS complex. That is almost like a rule. But there is always an exception to the rules. So in this case, the exception is a supraventricular beat can be conducted aberrantly through a ventricles, producing a wide complex. So that is one time a supraventricular beat can have a wide complex QRS. But normally, 95% of the times, all supraventricular rhythms are narrow complex rhythms, narrow QRS complex rhythms. Now, what are the types of supraventricular rhythms? First of all, PSVT or paroxysmal supraventricular tachycardia, atrial fibrillation, atrial flutter, multifocal tachycardia. Now, between these 4, how to differentiate these rhythms? Okay, these are all supraventricular rhythms, and they all have narrow QRS complex. Now, narrow QRS complex are there. Now you are in a dilemma to find out if they are, what type of supraventricular rhythm is that. So then next thing is you have to make sure if the rhythm is regular or irregular. A regular rhythm and narrow QRS complex is always a paroxysmal supraventricular tachycardia. A regular rhythm and narrow QRS is PSVT. And now, for atrial fibrillation, atrial flutter, and multifocal atrial tachycardia, the rhythm is always irregular, but they still have narrow complex. So we talked about all these 4 being narrow complex. The only thing is, these 3 are narrow complex, but they're irregular. Only PSVT is a regular rhythm with a narrow complex. Narrow complex is irregular rhythm, atrial fibrillation. Absence of discrete P waves, there's no discrete P waves. These rhythms are coming irregularly, so they're not regular. QRS is this wide and now this is coming sooner, and again there is a lot of gap between that. So irregular appearance of QRS complex. These are the two of criteria for atrial fibrillation. You can see fibrillating waves, okay? Narrow complex again. Supraventricular. Narrow complex irregular. Another thing is atrial flutter. You have flutter or sawtooth appearance waves, but still they are narrow complex. That is the point in atrial flutter. Narrow complex supraventricular irregular rhythm. Narrow complex irregular rhythm. Another one is multifocal atrial tachycardia. P waves vary in shape. See this shape of this P wave. This is different, this is different, this is different. They vary in shape, multifocal atrial tachycardia, okay? And they are, again, irregular. So, but the complexes QRS are narrow. So, now you got the idea, supraventricular narrow complex rhythms, and regular narrow complex is paroxysmal supraventricular tachycardia, irregular or atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. It is simple. Now, ventricular rhythms, always wide QRS complex. Supraventricular or narrow QRS complex, exception being the aberrantly conducted supraventricular beat. Ventricular complexes rhythms are always wide complex. It could signify one of two things: ventricular tachycardia, wide complex, or a supraventricular beat conducted aberrantly. This is supraventricular narrow complex and is aberrantly conducted, that is wide complex. Ventricular tachycardia characteristic feature is absence of any RS. There is no RS complex, QS, and wide complex. V1 to V6, that is 100% specific for VT. So ventricular tachycardia you should be able to diagnose. Now, by looking at the ECG, there are certain clues. Now, the only two, the wide complexes are always ventricular tachycardia with one exception. But how do you differentiate in ECG? Are there any clues? Yes, there are. In ventricular tachycardia, P waves and QRS are completely independent of each other. See, this P waves and QRS, this is up, and this is independent. Ventricular tachycardia, wide complex. Again, this is different. They're independent of each other. In VTAC, ventricular tachycardia, initial deflection of QRS initially is often in the opposite direction. See, this is a normal rhythm. Initial deflection of the ventricular wide complex tachycardia complex, QRS complex, is in the opposite direction before it started. See, this is upright, and this is in the opposite direction. That is one of the EKG clues of ventricular tachycardia as opposed to aberrantly conducted SVT. SVT with aberration in paroxysmal supraventricular, we talked about being a narrow complex supraventricular tachycardia with one exception with aberrancy. Okay. In PSVT, P waves bear one-to-one relationship with QRS complexes. There's always one-to-one relationship in PSVT. But in PSVT with aberrancy, initial deflection of QRS is in the same direction as that of the normal QRS. See, for example, this is normal QRS complex, okay, and then the aberrantly conducted thing is in the same direction, upright direction. So that means it's a wide complex, but since it's in the same direction as the initially conducted QRS, so you can safely call this as a supraventricular tachycardia if the heart rate is above 150. With wide complex, since it's in the same direction as the initial deflection, so it is a aberrantly conducted PSVT. I hope it is clear. Now, wide complexes we are talked about as being ventricular tachycardias. Again, one of the other tachycardias, abnormal rhythm, is torsades de pointes, which is seen in magnesium deficiencies, people having magnesium deficiencies. It is a polymorphous ventricular, it's also a ventricular tachycardia, and ventricular tachycardias are wide complex. The only thing is, these are wide complex. Only thing is the axis seems to be twisting in about the isoelectric line. So this is normal, it's coming, and then this is upright and suddenly twisted, the axis twisted, and it is bottom. This is called the torsades de pointes, and it's most commonly seen in magnesium deficiency. So I hope you understood this twisting at the isoelectric line. It's upright to down. That is the axis twisting. Ventricular fibrillation is an abnormal ventricular rhythm again. Ventricular tachycardia, if you don't do anything, it will degenerate into a fibrillation. It will lead into ventricular fibrillation if you don't act appropriately when you face a ventricular tachycardia patient. And ventricular tachycardias are wide complex rhythms. Fibrillation is a bizarre, irregular, no clearly identifiable QRS. There's no QRS clearly identified on this rhythm strip.